Okay, good morning. Today we are going to finish with the skeletal system. We have studied the histology of bone and cartilage. We have studied the gross anatomy of the bones of the axial skeleton and the appendicular skeleton. And today we are going to deal with the joints. So the joints are points of contact. Either they are located between bone and bone or between cartilage and bone. Remember these costal cartilages and ribs, for example. So this is a joint, or between tooth and bone. They are points of contact. It is not necessary that you might think that the joint should be movable. No, not all the joints in the body are movable. But there are certain types of joints that are movable joints. And this depends on the type of connective tissue that is, or the type of tissue, let's say, that is located between the articulating structures. So sometimes we have collagen fibers between the articulating structures, like for example here between the flat bones of the skull, there is a very short collagen, thick collagen fibers. So you expect that this joint is immovable joint. There's no movement taking place between the bones of the skull, but it's a joint. So again, I repeat, a joint is a union, an articulation, not necessarily movable. And then there is the second type is that there is a fibrocartilage in between the articulating bones, for example here, and this is called cartilaginous joint. So there is cartilage. Not always fibrocartilage, but there is cartilage, so it is called cartilaginous joint. Again, these joints, most of them are slightly mobile. There is a slight mobility. For example, like the joints between the vertebrae in the vertebral column, okay, the intervertebral disc. There is a slight mobility. And then the third type of joint, when there is a space, there's a fluid, synovial membrane, and these are the highly mobile joints. So whenever we need a mobile joint, the structure will be in the form of a synovial joint. Let's start with the first type of joint, the fibrous joint. They lack a cavity. There is no cavity. The bones are held together, as I mentioned, by connective tissue. There is little or no movement. So for example, on the suture between the bones of the skull, there is no movement. But in the other joints, for example here, which are called syndesmoses, we mentioned that before, between the radius and ulna, between the bones of the leg, tibia and fibula, there is a longer fibrous tissue called interosseous membrane. And this allows a little degree of movement between the bones. So this is a syndesmosis. Please do not mix this joint with the joints that are present here or here. These are the superior and inferior radioulnar joints, or proximal and distal radioulnar joints, and they are synovial joints, and they allow pronation and supination. So there is a wider degree or wider range of mobility taking place. I'm talking only about this fibrous tissue here. And the third one is the gomphosis, we call it. It is the joint of the tooth, between the tooth and its socket, the bony socket, which is present in a process either in the mandible or in the maxilla, and the process is called the alveolar process. So the process is alveolar process, and this is the socket. The tooth comes in and is connected to the bone by a ligament, fibrous tissue, which is called peri-around odontal ligament. And it is immobile, or there is a very minor degree, a microscopic degree of mobility. This is important to give us an indication about the degree of pressure, or about the pressure that, for example, when we bite. So the amount, give us an indication about the amount of pressure. And also, if you have something stuck in between your teeth, you will feel that, because there is a minor degree of mobility, microscopic amount. But if there is mobility, then this is a pathological condition. The second type, I want to orient you again. Joints are unions. They are not necessarily mobile. We classify the joints according to the type of tissue in between the articulating structures, which could be bone and bone, bone and cartilage, or tooth and bone. And So we studied the first type of joints, which are called fibrous joint. Now the cartilaginous joint. So there is cartilage. So it's either like, for example, here, direct articulation between cartilage and bone, and this is called synchondrosis. Or the other type is in the epiphyseal plate. Remember when we dealt with the growth of the bone, especially the growth in the length of the bone, we said that there are epiphyseal plate between the epiphysis and the metaphysis. These are cartilages that lay down bony tissue, and then at certain age, usually after 21 years of age, they will stop doing that. They will calcify, and what we say that they close. So this is again another union between bone and cartilage, and it is called epiphyseal cartilage plate. And the third type is the symphysis. We have many symphyses. One of them is the symphysis pubis between the two pubic bones. And in the symphysis, there is a fibrocartilage in between the two bones. This is the strongest type of cartilage. Remember, we said that there is a synovial, there is a hyaline cartilage, there is a fibrocartilage, and an elastic cartilage. This is the strongest type of cartilage, the fibrocartilage. It is present as a sandwich between the two bones, either in the symphysis pubis. Usually they are present in the midline, like the symphysis pubis, like the mandibulosternal joint here, the angle of Lewis, and all the joints between the bodies of the vertebrae, the intervertebral discs. They are all symphyses, and they are slightly movable. The third type of joint which produces movement is the synovial joint, and there's a cavity here. This is one of the features. And the second is that the two bones, the two articulating bones, they are covered by this bluish structure, which is a cartilage called articular cartilage. And usually this articular cartilage is hyaline, usually, not always, but usually it's a hyaline cartilage to reduce friction and absorb the shock. And then there is a capsule. This is the capsule, see? So there is a fibrous tissue capsule here. It has, and of course there is a space. So that's the capsule, which has an outer fibrous layer. And sometimes it is much thickened to form a ligament. And then the capsule is lined with the red structure, which is a synovial membrane. So it is lined with a synovial membrane that produces a fluid called synovial fluid. Synovial fluid is like a viscous fluid. It is clear, transparent, sometimes a little bit yellowish. It looks like the white, in appearance and consistency, it looks like the white of an uncooked egg. So that's why it's called synovial, ova from egg, synovial fluid. So this fluid has many functions. It bathes all these surfaces. It fills the cavity of the joint and is secreted by the red structure, which is the lining of the capsule. This fluid, apart from reducing friction, acting as shock absorber, remember that it carries nutrients and oxygen to this cartilage, the blue structure, because the cartilage is avascular. So it needs this fluid for nourishment, and at the same time remove the byproducts of metabolism. If there's any debris which results from the wear and tear of the use of the joint, then there are macrophages as well present in this synovial fluid, which will eat or remove these debris. So this fluid is very important, in fact, and actually, as I said, that it carries oxygen and removes CO2, so it has some gas dissolved in it. And whenever you reduce the pressure inside some of the joints, especially the joints of the knuckles, you will feel that these gas bubbles, they pop up, because the gas it's like when you open a bottle of fizzy drink, then you reduce the pressure, then the gas will come up. So that's why you hear the sound. It's not a friction between the bones. It's the pop up of these gas bubbles. That's why when you do it once or twice, then you cannot do it again. You have to wait, let's say, for half an hour until more gas is dissolved in, and then it can pop up again. This video is a very short video, but very nice. It's of the TED Talks, and it will deal with the synovial fluid function and the why do your knuckles pop. The other features of the synovial joints is that they have ligaments, accessory ligaments. These ligaments could be extracapsular, outside the capsule, and they are thickening of the capsule. Remember, as I said, that here the capsule can be thickened, so it forms a ligament. Remember, a ligament is thick, or it's a dense, regular connective tissue. So let's take the knee joint as an example here. We have, this is the lateral bone, so we have a lateral collateral ligament here. Or it's called fibular collateral ligament because it's attached to the fibula. On the other side, we have the medial collateral ligament, or they call it the tibial collateral ligament. Collateral means that it's on the side. So because this joint is a hinge joint, flexion and extension, so the ligaments, the thickenings, are on the sides of the joint. They cannot be anterior and posterior. So these are located in the capsule of the joint. But in addition to that, you can see that when you remove the capsule, there are other ligaments connecting between the tibia and the femur inside the joint. And these ligaments are the anterior and posterior cruciate ligaments. They are called cruciate ligaments because they form a cross. They are related to each other like the letter X, like a cross. So that's why they are called cruciate ligaments, anterior and posterior. And they are located inside the joint. Not all the joints have have ligaments inside them, but the knee joint has a lot of modifications. One of them is the presence of ligaments inside the capsule of the joint. But most of the synovial joints, they have capsules, extracapsular ligaments. Another feature of synovial joints is that they might have what we call an intra-articular disc or menisci. So this is an example of a joint having intra-articular disc. This is the temporomandibular joint. You remember here that there is a mandibular fossa in the temporal bone, and this is the mandible, which articulates here, forming the TMJ, the temporomandibular joint. The joint is divided into two compartments by a fibrocartilage, an intra-articular disc of fibrocartilage material. Looks like a cap if you look at it from the side. Another example here is in the knee joint, there is fibrocartilage like this one, which is called meniscus, lateral and medial meniscus. These menisci, they have the shape of like a C shape. So they are like this. If you look at them from above, we are looking at them from the front. But if you look at them from above, so they are something like that. They have horns here. And they are very important for stabilizing the joint and for changing the articular surface, making or modifying the articular surface. Because here, like for example, in the femur, the distal end of the femur has changing curvature. So during movement, these menisci, they open and close. So they are moving always when you move the joint in order to make the two bones fit to each other. Okay, and while they are moving, they are making ripples where in the synovial fluid and help spreading the synovial fluid. So they have a lot of functions. They act as shock absorbers. They make the articular surfaces fit to each other. They move the synovial fluid. But the problem is that these horns, they might be torn, easily torn, when the joint is hurt. And we will talk about it in a moment. This is called, they call them cartilages for the knee joints. When there's a knee joint injury, it might involve the ligaments and might involve the cartilages. Not the articular cartilages. The articular cartilages are present here. These are hyaline cartilages. But I'm talking about the menisci, intra-articular fibrocartilage. Then we have another term which is related to a joint, which is called bursa. Bursa is like a pillow that is filled with synovial fluid. So it's a pillow of synovial sheath filled with fluid. And usually it is located whenever there is friction between tendon and bone, bone and skin, so to reduce the friction. And some of these bursae, they communicate with the cavity of the joint. Like, for example, here, if you look at the knee joint, this is a longitudinal section in the knee joint. Look at the distal end of the femur. Look at the changing curvature here. And these are the menisci. You can see one of them, of course. This is one of them, but it has, because it has two horns, so when it is cut, you can see the horns. And there's the cavity. The cavity communicates with a pad of synovial fluid, which is located here. Suprapatellar bursa, above the patella. This is the patella, and this is the suprapatellar bursa. It reduces the friction between the tendon of quadriceps femoris and the femur. So this is an example of a bursa that communicates with the cavity of the joint. The same joint has another bursa between the patella and the skin to reduce friction between patella and skin. So it's called prepatellar bursa, and this bursa does not communicate with the knee joint. You can see here that this bursa gets inflamed because of excessive friction as it happens in this position, and inflammation of this bursa will give a clinical condition which is called housemaid's knee, because this is the way that this bursa gets inflamed and is exposed to a lot of friction. Another example of a bursa that reduces friction between skin and bone is the bursa which is located behind the elbow, between the skin of the elbow and the olecranon process of the ulna. And this gets inflamed in students, well, like mostly in students, because of the friction. And so that's why inflammation of this bursa gives rise to a clinical condition called student's elbow. So this is inflammation of this bursa. It does not communicate with the cavity of the joint, of the elbow joint. So the inflammation is not transmitted to inflammation of the elbow. It's only in the bursa. Some of these bursae are elongated and they form like tubes and they surround tendons. Like, for example, here, the long tendons of the flexor muscles of the hand. Remember last time I mentioned that we have long tendons passing through a carpal tunnel. So these tendons, in order to reduce the friction between them and between the bone and the carpal tunnel, they are surrounded by elongated pads of synovial fluid, and this might get inflamed in excessive friction, like for people typing or knitting, and results in excessive amount of synovial fluid when there is inflammation. And so the compartment is tight and result in pressure on a nerve that passes here, that is the median nerve. So this is about the structure of joints. Now let's deal with function, the movements that take place. And usually these movements take place at synovial joints, because the other joints, as I said, like fibrous joints, are most of them like immobile or slightly mobile. Cartilaginous joints, most of them are slightly mobile. So we are focusing more on the synovial joints where there is a lot of mobility. So it depends on the shape of the articular surface. Some of them, they allow gliding movements, like you can see here, or they allow angular movements. And these angular movements could be either flexion, extension. Remember these terms from the introduction. Like flexion is approximation of surfaces. Extension is straightening of surfaces. So that is flexion. This one is extension. This is flexion. This is extension. If it is beyond the anatomical position, this is, we call it hyperextension. Okay? Remember, this is the anatomical position. Not all the joints allow hyperextension. For example, in the elbow, I cannot hyperextend my elbow, but I can hyperextend my shoulder, go beyond the anatomical position. So that's the difference between extension and hyperextension. In hyperextension, you go beyond the anatomical position and not always allowed. And we have the adduction, which is movement toward the midline, and abduction, movement away from the midline. And then there is a combination of movement which is called circumduction. I will come to it in a moment. Then we have the movement of rotation, which is rotation around the longitudinal axis of the bone. So we have either medial or lateral rotation, and then we have special movements, as I will show you in a moment. So let's start with the gliding movement. Obviously, these are the bones that allow gliding movement. The carpal bones, small, tiny movements, like the carpal bones, the tarsal bones. Remember these joints when we studied between the ribs and the vertebrae, what we call vertebrocostal joints, head of the rib and the body of the vertebra, tubercle of a rib and the transverse process of vertebra. So these are a kind of gliding movements that take place in the joint. Most of the joints, or many joints, they allow angular movements in the form of flexion extension. So they are hinge joints. So for example, the elbow joint is a hinge joint. The knee joint is a hinge joint. It allows flexion extension. Ankle joint as well is a hinge joint as well, like the hinge of the door. Angular movement, we have adduction and abduction. Look at it here. This is abduction, adduction of the shoulder joint, adduction and abduction of the hip joint. Here is adduction and abduction of the wrist joint. For the fingers, it might be a little bit complicated because, as I said, by definition, adduction is movement toward the median plane, abduction away from the median plane. So for the fingers, usually we have the middle finger as the reference. So any movement away from the middle finger is a movement of abduction. This is abduction, and here is adduction. Okay, so we take the middle finger here, and this means that, in other words, the middle finger cannot be adducted because it is in the reference plane. It can only be abducted. If it is moved this way or that way, it is abduction. Both sides are abduction for the middle finger. In the lower limb, in the foot, it is the second toe, not the third toe. It is the second toe, the toe that is just lateral to the big toe. Now, what is circumduction? Circumduction is not a movement by itself. It is a combination of 4 primary movements. So as you can see here, circumduction of the shoulder joint, like when winding up to pitch a ball, it is extension, abduction, flexion, and adduction. So it's a combination. It's like drawing a circle in the air. This is true for the shoulder. It is true, I cannot do that, for the hip. Again, you can do circumduction for the hip. And it is true for the knuckles. This is circumduction. It is not rotation. See, this is circumduction. But rotation, at this joint, rotation is not allowed. At the metacarpophalangeal joint, you cannot rotate your finger like that at the knuckle. Okay? But at the shoulder joint, yes, I can rotate my shoulder so that the humerus rotates around its longitudinal axis. So this is a medial rotation, and this is a lateral rotation. It is different from circumduction. Circumduction is not a movement by itself, but a combination of 4 consecutive movements. It's different from rotation. This is rotation here, medial lateral rotation at the shoulder, at the hip. As I said, there's another rotation here I would like to attract your attention to, is between the first cervical vertebra, which is called the atlas vertebra. Remember, we said that there's atlanto-occipital joint, which is between the condyles of the occipital bone and the atlas. And this is the joint that we use when we say yes. So that's the atlanto-occipital joint. But we have another joint between the second cervical vertebra, which is called the axis, because the axis has a process. Looks like a tooth, so it's called the odontoid process. And the axis and the atlas vertebra can rotate around the odontoid process in a rotation. So this is this joint, which we call atlanto-axial joint, not atlanto-occipital. Atlanto-occipital is the yes joint. but the atlantoaxial joint is the no joint, okay? We have special movements apart from these common movements. We have special movements, for example, for the elevation and depression for the temporomandibular joint. When this is elevation, this one is depression, protraction and retraction. Also, the same movements are for the scapula. So elevation of the scapula, like in shrugging of the shoulders to show uncertainty, depression of the scapula, and retraction when the scapula approach each other, or protraction when the scapula moves as when delivering a straight punch, like that. So the scapula moves forward on the thoracic wall. This is a protraction, we call it, like the protraction of the mandible. So these are special movements. We have special movements between the tarsal bones, which is only present here. It's called inversion and eversion. As the name indicates, in, which means the sole of the foot looks medially, and eversion looks laterally. Probably we don't do this movement a lot, but actually we are doing it when moving on uneven surfaces. So our feet are moving like that between the carpal bones, and this is a movement of inversion and eversion. We have at the ankle, we call the movement dorsiflexion and plantar flexion, because in both cases it is approximation of surfaces. So that's dorsiflexion. Plantar flexion is the movement that usually taken by the ballet dancers. That's a plantar flexion. In the upper limb, in the forearm, I think that by now you should be familiar with pronation and supination. So there is pronation and supination. This is exclusive only in the forearm, and it takes place between the proximal and distal radio-ulnar joint. So supination is when you tighten a screw, and pronation is the opposite. Supination is when you rotate your forearm to attain the anatomical position. And then for the thumb, which is the most important of our fingers, there's a movement which is called opposition. Opposition is when you bring the thumb so that the pad of the thumb touches the pad of other fingers. And this is a very important movement for the precision movements, of the hand, as well as for the power grip. It is facilitated by the fact that one of the carpal bones that articulates with the metacarpal of the thumb has a shape of a saddle. So this allows the thumb to move this way. In addition, of course, there are muscles, the muscles that form this compartment, which is called the thenar muscles. Those are the muscles that are supplied by the median nerve. If you remember from last lecture, they allow opposition of the thumb. So this is, when you say opposition, there is no other opposition in the body except in the thumb. When you say pronation and supination, it's only in the forearm, okay? These are special movements. Now let's take another example here, which is the shoulder joint, or the glenohumeral joint, another name for it. It's a synovial joint of the ball and socket variety, because there's a ball here, which is the head of the humerus, and a socket, which is the glenoid fossa. It's a synovial joint, so both surfaces are covered by cartilage. Here it is hyaline cartilage. There's a capsule of the joint, the blue one, and there is a synovial membrane, red one, secreting the synovial fluid here, the yellow, the space, which is located here, okay? And you can see that this joint also has thickenings, which is not very clearly shown here, but it has thickenings, it has ligaments, but there are no ligaments inside the joint. Again, you can see here that there is a bursa, which does not communicate with the joint. It's located between this muscle, which is called supraspinatus, and beneath the acromion process. So it's called the subacromial bursa. It might be inflamed, especially in people who use their shoulder joint a lot. For example, it occurs in golf players, for example, as well. So people who you are manual workers, takes place. So it causes inflammation of the tendon. They call it supraspinatus tendinitis and subacromial bursitis, because this protects the tendon from rubbing against the bone. So you don't need to go into these details. I'm just mentioning examples. This ball and socket joint allows movements in 3 planes. So it allows adduction, abduction, flexion and extension, and then it allows rotation. So 3 planes are allowed, movements are allowed here in ball and socket joint. And another example of a ball and socket joint is in the hip joint, but the hip joint is more stable than the shoulder joint. One of the factors that causes stability of the joint is the shape of the articular surfaces. So as you can see here, that the glenoid fossa is not that deep, and it is small in comparison with the head of the humerus. So this will give more mobility to the shoulder joint on the expense of stability. Stability of this joint, the shoulder joint, depends more on muscles. And the most important muscles here are these muscles. Remember I mentioned about supraspinous fossa, and I said that there is a muscle called supraspinatus, infraspinous fossa, and then there is the subscapularis and subscapular fossa. So these muscles together, they constitute like a cuff around the shoulder joint, and they are called the rotator cuff muscles. They are very important for the stability of the shoulder joint. Another factor that stabilizes the joint are ligaments. So bone, ligaments, and muscles are the 3 main factors that stabilizes the joint. And depending on the structure of the joint, depending on the function of the joint, each one of them plays an important role in one joint, but not in the other. For example, here we depend more on the muscles in the shoulder joint, but in this joint, it's obvious in the hip joint that there's a very deep acetabulum, and which fits well with the head of the femur. So in the hip joint, definitely it is more stable than the shoulder, and this is what we need, because here that holds the body weight, it's used for locomotion. It's unlike the upper limb, we need it to move in space, free and move in space. So, but again, both of them are ball and socket joints, and again, this joint allows movement in 3 planes. Stability here, apart from the bony factor, depends on ligaments. And probably this is one of the strongest ligaments in the body. It's called the iliofemoral ligament, between the ilium, part of the hip bone, and the femur. In fact, the hip bone, which is formed of 3 bones, ilium, pubis, and ischium, it is connected to the femur by ligaments from each one of them. So, but the strongest is the iliofemoral, but yet we have the ischiofemoral and the pubofemoral ligaments. These are thickenings in the capsule of the joint. They are not located inside the joint cavity. This is the knee joint. Probably I talked a lot about the knee joint until now, and you will find in the video that will show you all the details about the knee joint, including the menisci, the anterior and posterior cruciate ligaments. Here you can see. These are the menisci again. See, they are C-shaped fibrocartilages, and these are the cruciate ligaments, intracapsular ligaments. And obviously here, the bony factor in maintaining this joint is negligible, because it's almost, the condyles of the tibia are almost flat. There's no socket here. But the menisci, the ligaments are important, and the most important factor in the stability of this joint is the muscle in the front of the thigh, the quadriceps femoris muscle. That's why it's always recommended to do the exercises for this muscle, and in cases of injury of the knee joint, because if it's not used, then it will atrophy, and the muscle and the joint will be less and less stable. And it has extracapsular ligaments, as I mentioned, the fibular and the tibial collateral ligaments. So it has so many structures related to these joints. This joint is liable to be injured, especially in sports injuries. This is the most common scenario that happens, that the knee is in a semi-flexed position. So it's semi-flexed and it is hit from the lateral side. So when the knee is semi-flexed, hit from the lateral side will result in injury of the meniscus, collateral ligaments, and cruciate ligaments. And usually it is the medial meniscus, medial collateral ligament, and the anterior cruciate ligaments, what they call it the unhappy triad. 3 of them might be injured. In order to diagnose this, they can do an arthroscopy. They pass a scope inside the joint, as you can see it here, and they can remove the torn meniscus or the torn part of the meniscus. Otherwise, this torn part will like lock the joints at sometimes or make the joint unstable because it's floating in fluid. And so they remove the torn meniscus if the problem is with the meniscus. But if the problem is with the ligament, especially a cruciate ligament, the anterior cruciate ligament, then it should be surgically treated. The knee joint is one of the joints that is subjected to a lot of body weight, and so wear and tear, degenerative changes take place. I think we mentioned that previously. We said that the cartilage is not sensitive, so this results in destruction of the bone, and the bone is sensitive, and then the patient can feel that. So these are the most commonly injured or the most commonly joints affected by osteoarthritis or osteoarthrosis because of the wear and tear, the hip joint and the knee joint. And because the cartilage is not easily repaired because it has no blood supply, as I mentioned before, so usually the treatment is replacement, arthroplasty. So you can see here that there is hip arthroplasty. We mentioned about arthroplasty last time when I said that there is a fracture of the neck of the femur can result in necrosis of the head. So they have to change the head and neck with a replacement here, a prosthesis, usually a ceramic or a metal prosthesis, as well as you can see here in the knee joint. Again, there's arthroplasty of the knee joint.